an option. Usually there's an option that says to live broadcast.
Okay.
I don't know where that went.
Okay, we are back online. I apologize to anyone who had trouble logging on initially. So, okay, so I'm sorry, go ahead and describe again.
So it's like it's in the dermis. We have palisading on the very edge of this kind of blue ball. It looks like this stroma. It's kind of fibromyxoid like underneath. I don't know if that's retraction
Yeah,
space.
so there's fibromyxoid, retraction space, peripheral palisade. So what are you thinking?
BCC.
Yeah, basal. Very good. Okay.
So right off the bat, dilated blood vessels right below the epidermis and papillary dermis. So I'm favoring something vascular at this point.
And what vascular thing will have dilated vascular spaces filling the papillary dermis, plastered up against the epidermis with hyperkeratosis, hypergranulosis?
I'm trying to remember the name.
You want to jump in?
Angiokeratoma.
Angiokeratoma,
Sorry.
that's it. Very good. No, that's good. So angiokeratoma, this is the angio part, this is the keratoma part. So it looks kind of prurigo or warty with compact hyperkeratosis, hypergranulosis, and then dilated vessels. It is not a proliferation of vessels, it's a dilatation of existing papillary dermal vessel in angiokeratoma.
So, looks like there's a little bit of like a papillary appearance of the epidermis, and then in the dermis you have kind of some fasciculations,
Yep.
spindled cells.
So you definitely have fascicles. So if you look at the fascicles of spindle cells.
And there's a little bit of maybe a Gren zone there.
It's a little bit of a Gren zone. If it were absent, you might handle this as a slam differential.
So is this a neurofibroma? So I'm in the spindle cell. I mean,
So definitely in a spindle cell category. Do the cells look S-shaped or more straight?
They're more straight. So
Tapered end or blunt, rounded? So kind of cigar shaped.
And there's a mitotic figure.
Yeah, and weird mitotic figures. So weird mitotic figures. Cigar-shaped nuclei usually go with
Like a fibroma, like a dermatofibroma.
cigar-shaped rounded on the end, usually with smooth muscle.
Oh, okay.
So then looking at these, is this the same cellularity as normal smooth muscle, or are there too many nuclei?
There's too many.
Too many nuclei for smooth muscle. So too many nuclei, lots of mitoses, atypical mitoses in something smooth muscly.
Myosarc?
Like a leiomyosarcoma, exactly. And one of the hints to it being muscle, the cigar shape when you catch it in a longitudinal plane, and when you look in a transverse plane, you see all of these little cytoplasmic vacuoles next to the nucleus. Muscle cells have to contract and work for a living, so they always carry their little glycogen snack in their back pocket. So that's their little snack. Okay. Christina.
This is a big, looks like subcutaneous nodule. Dating fat.
Okay, so big nodule.
And I have a
And then what's the growth pattern here?
It's infiltrative. I don't know what you mean. Oh, like the direction of it.
Yeah, so you have all of these very, very long parallel theques. The other name for that is a trabecular pattern, where they are wall-like, parallel walls.
Okay, so then when you say trabecular, I worry about Merkel being one of the things that goes in a trabecular
Exactly.
way.
So this is a blue cell tumor. There's blue, which basically means nuclei with no cytoplasm. There's comedonecrosis, suggesting it's probably malignant. It's a blue tumor with a prominent trabecular pattern, so that's most likely Merkel off the bat. Any stains you might want for confirmation?
Oh yeah. So we can put the DEA to make sure it's not basal cell, BCL, CK20.
And then for basal cell, some people will get Burr EP4. So for the fellows, how helpful will that be in this case?
I don't think it would do anything.
So what percentage of Merkel's stain with Burr EP4?
Enough to confound the diagnosis.
It's almost 100. So almost all basal cells stain with Burr EP4, so do almost all Merkel's. So, but synaptophysin might be good, chromogranin might be good, keratins for the para-nuclear dot.
And then which one's the one between lung and Merkel? That's
TTF1.
TTF1.
So thyroid transcription factor, although thyroid is in the name and it does stain thyroid, we use it for small cell lung.
Okay.
Okay, Jessica, what do you think?
So it looks like you have some tiny vascular spaces in this proliferation. And a little bit of a fibrotic strim around, like an angiofibroma or polypapule, but
So I see compact hyperkeratosis, a little bit of hypergranulosis and acanthosis. I have a vacuolar interface change. I have a big zone of pallor, and then I have a lymphoid band at the base of that big zone of pallor. Lichen sclerosis, very good. So lichen sclerosis has hyperkeratosis. We used to say lichen sclerosis et atrophicus. The problem is if you're scratching it all the time, it ain't atrophic. So now we just say lichen sclerosis, because it's often lichen sclerosis et hypertrophicus, if you've been scratching a lot. So compact corneum, either acanthosis or atrophy, often interface dermatitis, zone of pallor, lymphoid band. How would radiation dermatitis look different?
you're missing adnexal structures.
So missing adnexal structures, your vessels,
They're more ectatic. and
more ectatic, fibroblasts,
You have those stellate fibroblasts.
stellate radiation fibroblasts, and how about the lymphoid band? Absent in radiation. And then the last thing is if you see fibrous tracts, they are blue because there's vertically oriented radiation elastosis in every fibrous tract. And how would superficial morphia differ?
There tends to be more like a plasma cells and a lymphocytic infiltrate maybe. In
So
the
you may have plasma cells, you may have a perivascular lymphoid infiltrate. You'd expect some sclerosis of the collagen bundles with loss of space between the collagen bundles, and then again the lymphoid band absent in morphia. Okay. Very good. Okay. David.
Right. We have a acanthotic epidermis. There's some dilated capillaries close to the horn. The horn is kind of crusted, maybe perikeratotic, lots of neutrophils. So kind of in a psoriasis differential, I guess. P-tics.
So things that... So newts in the horn, psoriasis, tinea, impetigo, candida, sebderm, syphilis, P-tics.
Yeah, so a lot
You
of
pointed out the dilatation of the vasculature filled with neutrophils, which goes with psoriasis.
there's some
And your
spongiasis.
red cells form rouleau, which they rarely do in other inflammatory disorders, but fairly regularly do in psoriasis. And that's actually a good research project for someone, is to look at how specific rouleau formation is for psoriasis. But I see spongiosis. I saw psoriasis wasn't supposed to be spongiotic. Are there any forms of psoriasis that are spongiotic?
Yes.
So
Inverse,
which ones? Inverse,
erythrodermic,
erythrodermic,
pustular, acral,
acral, and
pustular,
guttate
guttate.
is the other. So the forms of psoriasis that are usually spongiotic: inverse, guttate, erythrodermic, acral, and other forms of psoriasis usually have no spongiosis. So you got to know the site to make sense of it. Okay. Let's see. We're a little thick here.
So, let's see. Looks like we had some hypergranulosis and acanthosis. In the upper papillary dermis, see some almost clear cell change.
It looks like clear cell change in its scan. You see what appears to be clear cell change in the epidermis. You might start thinking of things like Bowen's, sebaceous carcinoma, things that can have intraepidermal clear cell nesting.
Sure.
Let's take a closer look at those clear cells.
Organisms.
There are organisms in
So-
those clear cells. So looking a little closer.
Maybe something fungal.
So if it were fungal, what would it be?
Let's see.
If they're all the same size, then you'd think of,
Crypto? Or?
well, histo would be all the same size. Are these
Okay.
the same size, or are they pleomorphic?
Pleomorphic.
They are pleomorphic. So what would be pleomorphic yeast in a gelatinous capsule?
Is it crypto?
That would be crypto, correct. So given the degree of pleomorphism, I would say cryptococcosis. Hello.
Or no, history.
So what do you see?
So the epidermis looks a little acanthotic.
So epidermis a little acanthotic.
And in the dermis, I'm not sure if some of those are horns or they're...
So it's definitely connected to the surface epithelium, and you have a continuation of the squamous epithelium,
Mhm.
and it just keeps on going. You do have some neutrophil microabscesses. And it keeps on going into a more and more spiky pattern as you get into the dermis.
So I'm not sure what this is.
Okay. Any thoughts, anyone? So squamous cell carcinoma, basically squamous cells behaving badly going into the dermis. with the neutrophil abscesses, you might look at history and the possibility of whether it could behave like a keratoacanthoma. Look for things like elastic trapping and eosinophils. But this is awfully spiky, infiltrative pattern, so my guess is, despite the neutrophil microabscesses, it's going to behave more like a squamous cell.
It's like, excuse me, small tumor islands in the superficial dermis.
Okay. And what color are they?
Looks pretty blue.
Pretty blue. And
There's
what's
some
the little...
retraction there.
And some retraction.
So BCC.
So probably BCC. And then we always try to type BCC to see what it's going to behave like. So the superficial islands have lots of gray amphiphilic fibromyxoid stroma. But as we get to the deeper parts, the stroma is no longer fibromyxoid. It's becoming more solidly red, and the nests are becoming a little spiky.
So micronodular.
So micronodular if they're round, infiltrative if they're spiky. Both are aggressive types. It almost doesn't matter which one you call it. But loss of the fibromyxoid character of the stroma and the stroma changing to a red sclerotic stroma is a feature of aggressive basal cell carcinoma. So if that's present, it's a good tip-off that things are getting nasty somewhere down below. Okay.
Okay, so first glance we have what looks to be maybe an intradermal blister formation.
So blister formation, and you said intradermal. By that, I'll assume you meant subepidermal.
Well, yeah, I guess yes.
Okay, I'll buy that. And how old do you think your patient is? Old or young?
Looks like a young patient. Lots of collagen, thick.
What are the blue fibers here?
Is the just solar elastosis?
Solar elastosis. So a young, a tanning baby, or
or an older person.
Or an older person. Okay, so an older person with a subepidermal blister, and what's the subepidermal blister filled with?
Looks like it's filled with eosinophils.
So are they double nuclei like Mickey Mouse's ears, or are they segmented bodies like ants?
And neutrophils.
Neutrophils. Okay, so mainly neutrophils. So a subepidermal neutrophilic blister in an older person. So what's your differential?
I think about, so BP, but that I'd expect more EO, so
So
EVA is an option.
BP, but BP can be neutrophil rich. EVA, what
EVA,
else?
you can have bullous lupus.
Bullous lupus.
Think about PCT, but I don't see necessarily like
PCT, but the
festooning.
neutrophils would have to be there that it got secondarily infected. So subepidermal bulla with newts falls into your plaid differential. So P for pemphigoid, L for lupus, bullous lupus, A for EBA, I for linear IgA, and D for dermatitis herpetiformis. So you do IF on this, and this one has a picket fence vertical granular pattern of IgA at the DE junction.
So IgA, like linear IgA.
But it's granular, and they're like a picket fence vertically oriented along anchoring fibrils. So that's the DH pattern.
Okay.
So linear IgA is toothpaste linear, and DH are granules, but they're vertically oriented granules. So when you look at them, unlike lupus, they look like pickets on a picket fence because they go along the little anchoring fibrils.
If you were to like, because when I looked all that papillary dermal edema, I was like thinking less sweets with the neutrophils, but like if it was bullous sweets, would you expect like way more of an infiltrate in there?
So bullous sweets, you'd expect more of the edema to be here. So
Okay.
papillary dermis is what's above the postcapillary venial.
Okay.
Here, it's really a subepidermal split rather than edema within the dermis.
Okay.
Good question, because that would be an important point to differentiate the two. Caleb, what do you see?
Looks like a proliferation down into the dermis of what looks like keratinocytes. Those also look like horn cysts and a large follicle there as well.
Okay, so what do you think?
I was thinking maybe SEB, but I don't know.
Are SEBs normally infiltrative into the deep dermis or more an acanthome on the surface?
More an acanthome on the surface.
So this is something infiltrative into the deep dermis with horn cysts. When you look at these cells versus the cells peripheral, what do you think about the nuclear cytoplasmic ratio of the peripheral population?
It's decreased, or less cytoplasm.
Yeah, less cytoplasm, so increased NC ratio. So you have increased nuclear cytoplasmic ratio. If you look a little higher, you can see angularity and notching of the nuclear envelope, which goes with real keratinocyte atypia. Like this one, instead of being a round cell, see how it's got weird square edges to it? So that goes with real atypia.
It's more squamous cell.
Like squamous cell carcinoma, very good. Hold on. Oops.
That area in the field there makes me worry about an angiosarc.
Yeah, it looks kind of angiosarc-like. You have very small muscle fibers. But that could also just be baby skin with very small muscle fibers. But you definitely have a vascular proliferation, and you have areas where you have erythrocytes and no visible lumen. Any kind of pediatric tumor, well, first off, adult tumor that has spindle cells and erythrocytes and no visible lumen.
So in an adult, you worry about KS.
In an adult, you worry about KS. Is there anything caposiform in kids?
From meningoendothelioma.
So caposiform hemangioendothelioma, and that's a fine thing, right? You reassure the parents and everything's good?
You can get Kasabach-Merritt.
You can get Kasabach-Merritt. So it's the classic consumption coagulopathy in kids related to a vascular tumor. Well done.
So pretty diffuse, fairly purplish tumor.
Yeah, purplish or blue cell pattern.
It's got kind of a parallel feet pattern
Yeah, parallel-theque. What's the other name for a parallel-theque pattern?
Trabecular.
Trabecular. Any blue trabecular carcinomas that you know of?
Merkel cell.
What's the other name for Merkel cell carcinoma?
It's like trabecular.
Trabecular carcinoma. Yep. For obvious reasons.
Look, I saved it. You're welcome. Totally saved it.
So, large keratinocyte proliferation extending deep, or wait, no, I have skin on both sides. Hold
So thin patient or oblique cut.
on. Oblique,
Right.
probably an oblique cut.
Okay.
There's a good amount of an inflammatory infiltrate surrounding it.
Okay. So the body likes it, or body's not too happy with
Body's
it?
not too happy with it.
Body's not too happy with it. Okay.
The nuclei are large and vesicular with very conspicuous nucleoli.
Okay. And in the squamous world, does that mean much?
Not particularly.
Not a whole lot. So what means most of anything is you look at nuclear envelope. If it's thick and corrugated and irregular, that means a lot. And I definitely see some areas where it's refractile and you have irregularities. So, now I'm more worried that that's real atypia. Also, your nuclear cytoplasmic ratio is pretty high.
It all looks like it's still confined within a basement. Well, maybe not in some areas. I'd be worried about invasion.
Yeah.
It's hard to tell with the cut.
So
whether
invasive, and given that it's kind of a pale cell and area's clear cell carcinoma, what are your clear cell carcinomas in skin?
So you've got squame, can have a clear cell appearance. Sebaceous, but that's more vesicular looking, usually, or with red ducts and that sort of thing.
So, absolutely. So, squames, acrospiromas, clear cell Bowens, sebaceous. So, well done.
So we have rolls and scrolls and calcification.
So, rolls and scrolls and calcification.
Ghost cells.
What's your differential? Well, given that you picked out the ghost cells, then what's your diagnosis? Pilomatricoma. And in areas, it's not just calcification, there's actually osteoid there. So it is a bona fide pilomatricoma. It is a bona fide example of a pilomatricoma. Very good.
Proliferation in dermis with cells that have high NC ratio.
Okay.
Some of them either have the suggestion of glands or vessels. It's hard to tell.
Okay. It's a question of whether it's gland or vessel. The color of the nuclei?
Sort of gray, bluish.
And I'd say as you get to the linings of these irregular spaces, they're pretty dark. And the spaces are nice and regular or irregular.
Irregular.
And kind of crack-like throughout the splitting the collagen apart. So what do you think?
This being angiosarc.
So angiosarcoma, well done. Okay.
All right. So definitely have some acanthosis.
So acanthosis, and is the surface epidermis the whole lesion, or is there something hanging off the surface epidermis?
Looks like something's hanging off.
Something hanging off.
Mhm.
And the cells form a peripheral palisade.
Yes.
They're paler than the surface epidermis. And it's a little pale, but I can make out kind of a thick basal membrane zone at the edge there, right beyond the peripheral palisade. Clear glycogenated cells.
Thinking like I don't see a real strong delineation between the clear cells and the adjacent epidermis, but I mean, I'm thinking in the acanthoma.
So like clear cell acanthoma.
Yeah.
So clear cell acanthoma is the epidermis. It's a segment of the epidermis.
Okay.
This is something
This is
hanging
coming
off
off.
the epidermis. So clear cell, peripheral palisade, glycogenated, surrounded by a thick basal membrane zone. Anyone want to jump in? Trichulomoma. So remember, it's not surprising you missed because it's tricky.
It's tricky.
So the trichulomoma. And associations, trichulomoma and anything syndromal?
Cowden's.
Cowden's. Very good. That's good.
It looks like there is maybe some epithelial processes extending down
Okay.
into the dermis with the red stromal background.
So all of this is keratin.
Okay.
You can see that it's lamellar. It kind of splits into flakes.
Mm-hmm.
So it's a keratinizing tumor with pale areas.
Is it a keratoacanthoma?
So it's certainly crateriform. So things that help you differentiate Ka from conventional squame.
It would be more, it can be like involute, so the edges kind of roll
So
up.
sometimes you can see it actually involuting, and then it's declared itself as a Ka.
Mm-hmm.
But when it's not in the involuting phase, things that are predictive of that behavior, neutrophil microabscesses, well-differentiated glassy epithelium, hypergranulosis in follicles towards the center of the lesion, eos in the stroma, elastic trapping. It's been said squames push their way into the dermis, Kas pull their way into the dermis along elastic fibers. So you'd look at a little higher power and see if you can make out any of those things.
Biopsy here. It looks like there's a lot of necrosis in the epidermis.
So lots of necrosis in the epidermis. And what shape of the cells? Are they flat like keratinocytes normally would be near the corneum?
No.
Distinctly
They are,
round. And are they their normal size, or are they bigger round?
They're much
than-
larger, which makes me think of some viral changes.
And what kind of viral group tends to give you predominantly ballooning degeneration? The herpes group. And so then we look, because we have underlying dermis, and I don't see a whole lot of vasculitis, but we have some. And vasculitis with a herpetic virus suggests,
Varicella.
or zoster. Yeah. So VZV more likely than HSV when you see that. Okay.
Got a shade. Got a loose transcorneum. Here's some neutrophils. Keratosis.
So if there's neutrophils sitting on top of para,
Sandwich sign. You know, like psoriasis or PR.
which would go with psoriasis, PR can have focal parakeratosis, usually not the nudes. I see lots of spongiosis. Any forms of psoriasis that can be spongiotic?
Inverse acral erythrodermic guttate. Where is it?
Inverse acral erythrodermic guttate. You hit them. Just before. So, Rob.
All right, so let's see. See kind of loss of the reedy ridges.
Loss of the reedy ridges.
Kind of some crowding at the DEJ, maybe.
Crowding, and what are the cells?
Melanocytic.
Melanocytic. And there are at least doublets here. So they're doublets, crowding, little nest.
So maybe like, maybe thinking MIS.
So like MIS, and now let's pull way back. What's underlying that proliferation? I see vessels that are north-south,
Oh, yeah.
and collagen that's east-west.
So it's something been previously biopsied, probably.
Something previously biopsied. So what would mimic MMIS and a previously biopsied site?
Yeah, just like a recurrent.
Like a recurrent nevus. Very good.
Okay, so this looks like blue tumor islands.
Blue tumor islands.
With some hyaline drops.
And there's hyaline droplets of red, and they're surrounded by thick red basal membrane zone, and they form what kind of a pattern?
Jigsaw puzzle.
A jigsaw puzzle pattern. So this is?
Cylindroma.
Cylindroma. Very good. Anything that cylindromas are inherited along with?
Is it trichoepithelioma?
And trichoeps, and then that combination is called?
Is that Brooks-Spiegler?
That is Brooks-Spiegler syndrome. Very good. Or Rasmussen, same syndrome.
Looks like I see some ghost cells in there as well.
So ghost cells.
Don't see any bone.
Don't see any bones. In the absence of bone,
Pilomatricoma.
pilomatricoma, we can't say it's a
Non-bona
bona fide example, but pilomatricoma nonetheless. Let's see how we're doing time. They paged me that patients are already building up in clinic.
Alright, so very thick corneum, looks like an acral surface, some
So acral
acanthosis
skin.
changes like peripherally around the central growth. Looks like you've got some clear cells, kind of viral changes throughout it.
What color are these inclusions?
Seem to be like a reddish pink
Okay.
inclusion associated.
So, red inclusions, acral site, endophytic,
Sounds like a myrmecial.
like myrmecia type wort. So, very good. And myrmecia means?
Endophytic word.
Means anthill. So, it looks like kind of like an anthill that burrows. Okay, well, that's good.
Large blue tumor in the dermis.
Large
And
blue
blue
tumor in the
pink.
dermis.
Peripheral
Peripheral
palisade.
palisade. So certain things do palisade, like basal cell and trichomoma palisade. Things like acrospiromas never palisade. So it's helpful to differentiate.
That's a pretty good band around it. I don't think the stroma is particularly fiber mixoid, so I was thinking like trichomonas.
So you're thinking like a trichoblastoma?
Yeah, trichoblastoma.
So you want to look at the stroma and see, is it a concentric fibroblast-rich stroma? One of the hints here is that we have a superficial BCC budding off the epidermis, which trichoblastoma wouldn't do.
Right.
So it's just a great big adenoid BCC. You can see the adenoid spaces. Thanks, Kate. First off, what's all this stuff?
That's the surface. Looks like all just necrosis and a lot of neutrophils mixed in there, and that's probably bacteria.
Yeah, exactly. So those are all just huge staphylococcal colonies. So this thing is heavily impetiginized, heavily covered with staph. Then you have a neutrophilic crust.
I mean, it's vascular. I think about like a PG that somebody picked at.
Exactly. So like an impetiginized PG. The only thing that I'd like to see that we don't see here is it's not distinctly lobular, like a PG, but that's still probably what it is. So, you know, crusted granulation tissue or PG, I'd like to get a better look at it.
So pretty marked orthohyperkeratosis, but then all of a sudden it goes away.
And if this was circumscribed on a palm?
It's the, I know there's a name for it, it's very descriptive. It's like the hypokeratotic.
It circumscribes palmar.
Circumscribed palmar.
Hypokeratosis.
Yeah.
Correct. And what is the etiology?
Is it like a keratin defect? Or?
You know, all kinds of things like that were hypothesized, and now there's good evidence that you were trying to be a handyman about 2-3 weeks ago, and you were, you know, torquing a screwdriver or something with your palm. You don't even remember the injury, but now all that corneum sheds. So it's almost like a delayed friction blister type of thing. So trauma. But they look absolutely blood red. So when you look at it, you're thinking tumor of some sort because you've got a circumscribed blood red area of your palm. Your palms would all be blood red if you didn't have such a thick corneum. When you shed that corneum, you see the red through it.
Do palmar pits look similar though? Or they both have like
The palmar pits are punctate, and those don't look red, and they don't look red because there's a proliferative epithelium like in nevoid BCC there that blocks the optical red, whereas this is a patch that's blood red. Okay, Nicole, what do you think?
So you have kind of a cystic dilation that's lined by kind of low cuboidal type cells. There's lots of
filled with
blood.
Okay.
So I could be thinking that it could be something vascular.
Okay, and if it's vascular, lined by just 1 or 2 layers of these roundish cells.
At first I was thinking like something like a glomacy, like glomangioma.
Yeah, glomangioma. That's exactly right. So glomus tumors tend to be solitary and painful. Glomangiomas tend to be multiple, inherited, and painless.
sort of looks like basal cell, like superficial basal.
So you got superficial BCC, and if that's superficial BCC, then what's the deeper stuff?
So nodular.
Yeah, nodular is all contained within tumor stroma. If those little islands go beyond the tumor stroma, then you'd say micronodular or more aggressive subtype. Very good. And with that, we are done.